So I'm curious how this, we've got a global panel here, and I think unique perspectives here are important. How does this impact practice for you in Switzerland? Is this something that you're routinely doing already? Is it waiting for OS to come out before you can use it? How does this impact you every day?
Yeah, so you will see during this kind of discussion in Switzerland, you're very fortunate because we have a very early access to many drugs through a registration program or through a compassionate program. So we have access to durvalumab since the PFS data very soon after the publication of the New England. And we have been starting to routinely deliver it. I had the opportunity to write the editorial of this New England with a colleague, and we just concluded that the magnitude of benefit, a little bit of irrespective of survival at the time, was already supporting the delivery of durvalumab. So we had started at the time. Now that we have the survival data, it even confirms what we are doing. And I think that stage 3 is treated with a very heavy treatment, multimodal treatment, in order to try to cure. We still cure, 15, 20, in the very good clinical trials, 30% of them. So whatever you use which might increase this cure rate is really something you shouldn't discuss.
I think we've been in a vacuum for a while in stage 3, and to have these drugs. I'm just curious, the French and UK experience, is this something that you're routinely using? Maybe Sanjay, you can start. Is this ready? Are you using it? And if not, when do you think you'll be able to use it?
Yeah, thank you. So I think this is a game changer for stage 3. This really is. And the survival data really do cement the early data that we had on progression-free survival and time to distant metastatic disease. So the regime is not routinely commissioned in the UK. However, there is a scheme that the drug is made available. And there has been a lot of reticence in taking this up in various parts of the UK, mainly around skepticism of progression-free survival as
and whether that
the
would
endpoint, whether that would really translate to a survival advantage. Now we've seen that survival advantage, and I really would encourage the rest of the UK community really to follow on with this fantastic data that we have here and ensure that we are able to deliver concurrent chemotherapy with radiotherapy to this group of patients to ensure that we then fit in the trial paradigm to allow durvalumab consolidation.
Very good. Any French perspective on this?
I would say same in France. So that means we are quite convincing by the PFS, the magnitude of benefit in PFS that never have been observed with all the previous trial. So we were quite convinced, most of the oncologists and the radio-oncologists in France. So we have nowadays an expanded access program. And so that means all the patients, stage 3, that might receive an immune treatment in consolidation with durvalumab, they receive already the treatment. So this is in our standard, and we routinely do this. So we used to see the patient 2 weeks after chemo and radiotherapy with a CT scan evaluation to be sure there is no tumor evolution, and within 4 weeks, the patient already started the durvalumab. So we were convinced, nowadays we are 100% convinced by the overall survival. So I think there is no doubt on the discussion. The only discussion that we will have, and for which we might have the discussion, is about biomarker. Is about PD-L1, because it will be restrictive to the PD-L1 positive patient in Europe. And I think it will be a big issue. And we may have the discussion because we are not convinced that the PD-L1 negative do not benefit of this type of treatment. So that's why it will be something we might discuss, and how to under-treat patient PD-L1 negative, because nowadays we treat this patient and they might bring also benefit in this population.
Yeah, it's interesting. Well, I guess we'll see what the PD-L1, we'll have a full paper very soon on this, and to see what the PD-L1 low less than 1, and did that benefit, was the benefit there in those patients. The U.S. perspective has been interesting, and I'd ask Ram to kind of chime in here. You know, the Durva consolidation story has changed things for us at Hopkins a little bit. We were very much using concurrent chemoradiation followed by a couple of cycles of consolidation. And if you look tucked in the appendix of this trial, the earlier you gave the Durva to radiation, the better off these patients did. So we've kind of done away with the consolidation. Consolidation was not allowed in the Pacific trial. You know, roughly 25 or 30% got induction. Ram, any thoughts on this? Has this changed the way you scan patients, the timing of the scan, whether or not to give consolidation or not? How's this impacted?
So Ben, when I looked at the survival data from Pacific trial presented at this meeting, there were two things that struck my mind. One is the hazard ratio for overall survival was 0.68 framing durva. What that means for our patients is a greater than 30% reduction in the risk of death as a result of receiving consolidation durva. I think that's unprecedented, as our colleagues here have pointed out. The second thing is the question of what's the median survival. Well, the good news is the median survival has not been reached for patients on the durva arm, despite having a very robust follow-up. So obviously, that's another exciting piece of news coming out of this. And this really firms up the fact that durva will now be considered the standard of care in stage 3 disease after chemoradiation therapy. Now, consolidation therapy is something that we have tried in the past. Even before the Pacific readout, I would say the enthusiasm for consolidation therapy was piece by piece waning away because of incremental evidence that that really doesn't help. We can certainly say there is no proof that consolidation chemo improves survival. We have a treatment that improves survival in durva. So I think it's an easy change in paradigm where patients get chemoradiation. Once they recover from acute toxicities within the 4-6 week period, they would then go on to receive durvalumab.
Do you scan them after 1 to 2 weeks after they're done with radiation to confirm stable disease and then move them right away, or do you hold off on a scan until 4 weeks just to get the maximum benefit from radiation? Or
our multidisciplinary team believes that you've got to wait for a few weeks after chemoradiation before you get a good readout for the degree of benefit with chemoradiotherapy. So our first scan is typically around 4 weeks, and that's also the time I would bring the patient in to start the consolidation durva. So that flows well in our clinic.